Posterior interosseous nerve pin compression syndrome is a condition where the pin, a branch of the radial nerve, becomes compressed or entrapped, leading to weakness or paralysis of certain muscles in the forearm. This syndrome is often confused with other nerve or muscle disorders, but understanding its unique causes and anatomical features is crucial for accurate diagnosis and treatment. In this video, we'll explore the main causes, anatomical considerations, and common sites where the nerve can become compressed, setting the stage for a deeper dive into this important clinical topic. Several factors can lead to pin compression. Among the most common are radiocapsular joint ganglions and synovitis, which can create space-occupying lesions near the nerve. Congenital tightness of the ligamentous arcade of Froese is another frequent culprit, as this anatomical structure can naturally compress the nerve. Additionally, surgical interventions, especially poorly placed screws during fracture fixation of the proximal radius, can inadvertently trap or injure the pin. Understanding these causes helps clinicians anticipate and prevent this syndrome during both diagnosis and treatment planning. Pin is particularly vulnerable during open reduction and internal fixation (ORIF) of proximal radius fractures. In about 25% of patients, the nerve lies in direct contact with the periosteum of the radius just behind the bicipital tuberosity. If a fixation device, such as a plate, is applied to the radius with a proximal screw at this level, the nerve can become entrapped beneath the plate. To avoid this serious complication, surgeons should always directly expose the nerve during the procedure, ensuring it is not inadvertently compressed or damaged. Not all cases of pin compression have an obvious cause. Idiopathic compression syndrome refers to cases where the nerve is compressed without a clear external factor. Several anatomical sites are prone to causing this type of compression. These include fibrous bands interior to the radial head at the entrance of the radial tunnel, the radial recurrent vessels known as the leash of Henry, and the tendinous origin of the extensor carpi radialis brevis (ECRB). Each of these locations can create pressure on the nerve, leading to symptoms. Arcade of Froese is the most common site of nerve compression in radial tunnel syndrome. This structure is the tendinous proximal border of the supinator muscle and lies deep to the extensor carpi radialis brevis. Its anatomical position makes it a frequent culprit in pin compression, especially when the arcade is unusually tight or thickened. Understanding the relationship between the arcade of Froese and the pin is essential for both diagnosis and surgical intervention, as this is where most compressive lesions are found. While the arcade of Froese is the most common site, other locations can also cause pin compression. The distal edge of the supinator muscle at the nerve's exit is the least common site but still clinically significant. Compression at this point can result in similar symptoms and should be considered, especially in patients who do not have obvious lesions at more proximal sites. Recognizing these less common sites ensures a thorough evaluation and prevents misdiagnosis. Several key anatomical and clinical studies have shaped our understanding of pin compression. Notable references include research on the arcade of Froese and its relationship to posterior interosseous nerve paralysis, as well as anatomic and morphometric studies in cadavers. These works provide valuable insights into the variability of nerve anatomy and the importance of careful surgical technique. Additionally, comprehensive reviews on radial nerve entrapment at the elbow and peripheral nerve compression offer guidance for both diagnosis and management. Distinguishing pin compression syndrome from other conditions is critical. One important differential diagnosis is C7 radiculopathy, which can present with similar symptoms but has different underlying causes and treatment strategies. Unlike pin syndrome, C7 radiculopathy involves nerve root compression at the cervical spine and may present with additional sensory changes or reflex abnormalities. Careful clinical evaluation and appropriate imaging are essential to differentiate between these conditions and guide effective management. Summary: posterior interosseous nerve compression syndrome is a complex condition with multiple potential causes and anatomical considerations. From surgical risks to idiopathic compression sites, understanding the detailed anatomy and common pitfalls is essential for clinicians. Accurate diagnosis relies on a thorough knowledge of the nerve's course, common sites of entrapment, and differentiation from other neurological conditions. By staying informed and vigilant, healthcare providers can improve outcomes for patients affected by this challenging syndrome.